Welcome, everybody, to the next Virtual Pathology Grand Rounds, co-hosted with the American Society of Clinical Pathology. We are really fortunate here today to have Dr. Carla Ellis here to talk to us about Renal Pathology Made Easy, a concise review of medical renal pathology with board-relevant topics. Dr. Ellis is currently an associate professor of pathology at Northwestern University. She obtained her bachelor's in science in psychology with honors from Howard University on a full women's volleyball scholarship, where her jersey is currently retired, and she was inducted into the Athletic Hall of Fame. She went on to obtain a master's degree in anatomic pathology at the University of Maryland and began her career as a pathologist's assistant. She proceeded to medical school at the University of Nevada and completed her pathology training at Johns Hopkins, where she received the Joseph Carl Eggleston Award for Excellence in Surgical Pathology Research and published numerous articles in genitourinary and renal pathology. Dr. Ellis spent the beginning of her career on faculty at Emory University, where she received not one, but two Golden Apple Teaching Awards and the Anna Lee Boyd Award for outstanding teaching and support of the residency program. She also began a wellness program for trainees and served as an ambassador for the USCAP. Dr. Ellis joined fellow Chair Dr. Dan Bratt at Northwestern University, where she serves as the Director of Wellness, Diversity, and Inclusion and is the Medical Director of the Renal Biopsy Service. She is a founding member of the Society of Black Pathologists and the immediate past president, and was also inducted into the Alpha Omega Alpha Medical Honor Society. So we are really, really fortunate to have Dr. Ellis here today to teach us about renal pathology. And just as a little housekeeping, our ASCP staff will be putting information about claiming CME into the chat a little bit later. Welcome, Dr. Ellis.
Thank you so much, Sarah, for that amazing introduction. And thank you to all the participants. Thank you to the ASCP for inviting me for this opportunity. I really, really enjoy and cherish renal pathology. So it's something I love speaking about and teaching about. Just want to give a quick disclaimer. First of all, expressing gratitude for everyone who has come on. I always find it a little unbelievable that people want to hear what I have to say. So I really, really appreciate that. I also want to apologize in advance. This is a lot of information, It's impossible to talk about all of renal pathology within 45 to 50 minutes. So I'm going to kind of move fast and have time for questions at the end. There's a chat function and a Q&A function. So please feel free to use that as you go along. And then again, Dr. Gonzalez will be helping me with moderation of the Q&A and questions and answers afterward. So we'll dive right in. Just making sure that everyone can see my screen and can see my cursor here moving around. Hopefully, Devin or Sarah or Raul, if anything goes wrong throughout the recording, please unmute and let me know so I can fix that right away. I'm going to go ahead and stop the video for me now, just because I think it's a little bit distracting for me to see everything, and I want to really focus on the slides, and hopefully you will too. So let's get started. All right, so my main question today that I want to try to answer for you is, why is renal pathology so complicated? Why is it looked at as a specialty that perhaps a lot of our pathology residents don't want to pursue, and it's just super complicated? And a little bit of that is because it's such a complex subject. It's a complex clinical presentation with a lot of important laboratory values representing a very complex pathophysiology. When I get a prostate biopsy, the only clinical history I have, if I have any, is elevated PSA, and that's it. We look at it, we do our Gleason grading and our grade grouping and sign it out. With kidney biopsies, there's a lot of information. We need to know the duration of the disease, any other medical history, family history, any prior history of genetic diseases, any other non-renal systemic diseases. Those are so important when you're evaluating a kidney biopsy. You also have to have a lot of laboratory values. We need the creatinine, we need the urine proteinuria level, we need a urinalysis, the BUN, any serologic titers. All of these things are so important for the analysis of a kidney biopsy so that it can tell us what we need to know for the diagnosis. The other thing that's complicated about it is that we have 3 different modalities in order to get to the final diagnosis. It's not just the light microscopy. We have to pair with that the immunofluorescence microscopy and the electron microscopy in order to make an accurate diagnosis. So that's why renal pathology is so complicated, but I ensure you that it's an amazing field. And if you have any interest in it, please do a rotation if you're a trainee, or chat with your local renal pathologist about some of the shared cases that you might have. One way to make it easy is to always consider the clinical presentation, and we'll talk about nephrotic versus nephritic presentations, because that can really sort of divide up what the potential diagnosis might be. And then using all three of those modalities to fit together to make the final diagnosis: light microscopy, immunofluorescence microscopy, and electron microscopy. Also understanding that a kidney biopsy is just a snapshot in time. So depending on how long the patient wasn't feeling well, or until they presented to the hospital and got the biopsy, or they may have gotten treatment, they may have gotten pulsed with steroids, that can really change the findings on the kidney biopsy. So I always have to keep that in mind when I'm making the diagnosis, and particularly when I'm communicating that to the clinical team. And that is also key in renal pathology, maintaining that good communication with the clinical team. So we'll start off talking about nephrosis and the nephrotic syndrome. In the image, you can see this poor guy laying in a bed with a lot of swelling and edema. He's got anasarca, and that's one of the key features of nephrosis and the nephrotic syndrome. It's just a lot of edema and swelling. This is you're going to see a lot of sort of cartoons or illustrations throughout this, because I think that those illustrations really portray the pathology, the histopathology of renal disease in a way that's sometimes almost as good as the actual histopathologic findings. So getting back to nephrosis, we have at the top glomerular damage, and we'll get into the details of that later. That's sort of the start of it with nephrosis. With that glomerular damage, we have increased permeability of these glomerular capillaries to protein. As a result, we have protein in the urine, proteinuria, and nephrotic range proteinuria for the residents is determined as greater than or equal to 3.5 grams per day of proteinuria on a 24-hour study. That's a key number to really keep in mind. If you're spilling too much protein in the urine, then you will have less protein in the blood, leading to hypoproteinemia. So if we have an albumin level of less than 3 grams, that's key to the nephrotic syndrome as well. At this point, we split off into two paths. The one on the left is a little bit more reproducible. If we have too much protein in the urine, not enough in the blood, we have decreased plasma oncotic pressure that can cause not only fluid to escape into the tissue and cause that overall anasarca type swelling, but we have decreased plasma volume, decreased glomerular filtration rate, decreased aldosterone secretion, and increased fluid retention, also leading to edema. The other pathway is sort of compensatory synthesis of proteins by the liver, leading to hyperlipidemia, which we can see in the nephrotic syndrome, that somehow feeds back and increases the glomerular damage. This is a pictorial supported by one of my colleagues and a great mentor to me, Dr. Mark Haas. So let's dissect a glomerulus. This is the anatomy of a glomerulus. Here on the far left, you'll see that contrary to most capillary beds, a glomerulus is a specialized capillary bed that begins with an arteriole and ends with an arteriole. Usually we have an arteriole leading into a capillary bed, ending in a venule, and then progressing on to veins, because that's where gas exchange occurs in typical capillary beds. The glomerulus is a specialized capillary bed that begins and ends with indicators of the arterial system. So we have the afferent arteriole that leads into the glomerulus. We have a support system of these purple cells called mesangial cells that keep this capillary loop supported together. We have the glomerular capillary loops where blood is filtered. We have these teal-colored visceral epithelial cells, which are also referred to as podocytes, that extend processes out and to become foot processes that line the external surface of the capillary loops. And then we have these pink-colored endothelial cells that have a fenestrated lining that line the inside of the glomerular capillary loop. A very important cell to also remember is our parietal epithelial cells, these teal blue cells that line Bowman's space. So when blood comes in and it's filtered by the glomerular capillary loop, it collects as urine in Bowman's space, which is lined by visceral and parietal epithelial cells, collects as the ultrafiltrate, and then exits the glomerulus through the proximal tubule. All of these proximal tubular epithelial cells have complex physiologic functions that eventually turn the ultrafiltrate into urine. It leaves proximal convoluted tubule, distal convoluted tubule out of the kidney into the ureter, to the bladder, then out the body through the urethra. So that's a very quick summary of what happens in the glomerulus. Here we can see the same photo, and then we can have the histologic image of the same thing. So all of those very important cells that I pointed out on the cartoon are also here and labeled with a lowercase m are our mesangial cells. This is a silver stain, by the way. The C is the capillary lumen, as you can see here. The lowercase e is the endothelial cell nucleus that's lining the inside of the capillary lumen. And the P are the podocytes, the visceral podocytes. B would be Bowman's space, and then we have Bowman's capsule outlined here. On the left-hand side here, we have a very important feature, and that is the electron microscopy image of a normal capillary loop. Key is normal. I see normal so infrequently that I really think it's good to look at that and use it as a teaching tool to indicate disease. So I've color coordinated everything for you, where red is the mesangial cell, which is here too. Yellow is the fenestrated endothelial surface, as you can see here in yellow. Gray is a glomerular basement membrane that sits sandwiched between the endothelial cell, the fenestrated endothelial cell layer, and the podocytes up here that are not effaced. They all stand up, separate from each other, respecting each other's space, minding their own business, and giving each other space. If you take this box here and blow it up, you'll get a higher power image of the sandwich. So you have an erythrocyte belonging where it should go in the capillary lumen. We have the fenestrated endothelial cell surface with the fenestra right here. We have the basement membrane, and then we have our podocyte foot processes with very visible filtration slits in between. These are the foot processes. This 3-segment layer is what I refer to as the triple barrier to loss of protein. That's what's keeping protein in the blood and outside of the urine, because this is normal. When this process goes wrong is when we have, again, too much protein leaking out into the urine. So this gray arrow here shows the direction of the filtrate from the plasma into the Bowman space as ultrafiltrate. So everything normal here, color-coded. Once we begin to have injury to these foot processes, that's when we see foot process effacement. And that's a key finding in a lot of diseases with proteinuria or nephrotic diseases. Let's go over that a couple more times. So here we have these teal little ovals here that are the fenestrated endothelial cell layer. We have this peach colored glomerular basement membrane, and then we have our podocyte foot processes with their very clear and demarcated filtration slits. Some kind of injury, be it an antibody, a cytokine, a toxin, allergic reaction, or familial disease will cause injury to this process and cause effacement of these podocyte foot processes, where instead of being upright and separated, they come down. They have less room between the filtration slits, and they're injured and they lift off of the glomerular basement membrane. So that's what's causing protein to leak into the urine. Let's do this one more time, different colors. We have albumin and red blood cells in the capillary lumen and the flow of molecules going out this way. We have our endothelial cell layer, our glomerular basement membrane, and our podocyte foot processes that not only showing the filtration slits, but also the actin cytoskeleton that keeps them lifted upright and separated from each other. Once we undergo injury of some sort, then we have collapsed podocyte foot processes that fuse. There's reorganization of the actin skeleton, and then there's loss of albumin and protein into the urinary filtrate. So in those diseases, when we look at the electron microscopy, we have effaced podocyte foot processes. Where are our filtration slits? Where are our standing up with a intact actin cytoskeleton foot processes? They aren't there because they're damaged. So just a little bit of orientation: red blood cell in the capillary lumen, fenestrated endothelial cell layer, glomerular basement membrane, and effaced podocyte foot processes. Contrary to that, we have nephritis. So before, with nephrosis, we saw the guy, a very indolent disease in the bed, lots of swelling. It takes time to develop that. With nephritis, it's much more acute and much more associated with hematuria. So we can do a similar flow chart for nephritic diseases. We have inflammation in the capillary lumens, injury to the capillary wall causing blood loss and hematuria. We have a lot of hemodynamic changes. We still have decreased glomerular filtration rate, but here we have oliguria, decreased urine output, and azotemia, which is increased creatinine and acute kidney injury. That causes sodium and water retention and increased plasma volume, leading to hypertension. Because of the increased plasma volume, we do get a little bit of mild edema in nephritic syndromes, but much, much less than we see in nephrotic syndromes. And the three things by the pink stars are what we really focus on in nephritic syndromes. So just as a side-by-side comparison, we have the typical features, nephrotic on the left, nephritic on the right. The onset is insidious in nephrotic syndrome and abrupt in the nephritic syndrome. Edema, much more voluminous in the nephrotic syndrome. Some, but very much less than in the nephrotic syndrome, edema in the nephritic syndrome. Blood pressure is normal in nephrotic, raised in nephritic, same with jugular venous pressure. Proteinuria is increased in nephrotic, mildly increased in nephritic. Hematuria may or may not even occur in nephrotic syndrome, always present in the nephritic syndrome. Red blood cell counts, absent and present. Hopefully you're getting the gist here. Serum albumin is low because we're losing it in the nephrotic syndrome and only slightly reduced in the nephritic syndrome. Once again, I like repetition. In the nephritic syndrome, we have oliguria, hematuria, decreased GFR, non-selective proteinuria, a little bit of mild edema and salt and water retention with hypertension and red blood cells in the urine. That's why the urine bottle on the nephritic side is low and the urine is orange because of the hematuria, and the oliguria causes decreased urine output. On the nephrotic side, we have a lot of proteinuria, nephrotic range, we have a lot of edema, hyperlipidemia, lipiduria, and protein cast, and a normal degree of urine, but it's pale yellow in color due to all of the increased protein. And on the nephritic side, you may be wondering why this little girl with a red rash on both of her cheeks may be here on the nephritic side. We'll talk about that later. That is a butterfly malar rash in lupus nephritis. And this little guy has periorbital swelling, which can be seen in nephrotic diseases. So just to tie it all together, a colleague of mine, Edgar Lerma, tweets at these cartoons that sort of tie things together, and they're really good for my medical student teaching. With the nephritic syndrome, we have that hypertension, inflammation in the glomeruli, and oliguria, no urine output. We have hematuria, causing the cocoa-colored urine. And since the other name for IgA nephropathy, which is the most common primary cause of glomerulonephritis, is Berger disease, which can be really pronounced Berger, but they are saying burger because the Burger King and the IgA and the cocoa-colored urine, et cetera, that's characteristic of the nephritic syndrome. The nephrotic syndrome, you have hypoalbuminemia. There's none of these blue circles inside of the vasculature. You have hyperlipidemia. The most common cause of nephrotic syndrome in children is minimal change disease. So they've characterized this as a child with all this peripheral edema, massive proteinuria, and the dog is drinking the urine sample and thinking about muscles because it's of the protein, I guess like a protein shake. So now that we've run through that, let's go through some of the prototypical nephrotic renal diseases that I see on a daily basis. Again, minimal change disease, very common in children. Focal and segmental glomerulosclerosis, or FSGS, hopefully most of you have heard of these. Membranous nephropathy or membranous glomerulonephritis, diabetic nephropathy, and renal amyloidosis. All of these diseases are characterized by some degree of proteinuria, but have completely different histologic findings on the biopsy, which is why I said the key to making renal pathology easy is number one, knowing the clinical presentation of nephrotic syndrome or nephritic syndrome, and then looking at the findings by light, immunofluorescence, and electron microscopy to make the diagnosis. So let's go over a normal glomerulus by light microscopy. We won't see a normal one again for a little while, but to just emphasize, these capillary loops are wide open and patent. There's no proliferation of cells inside of the capillary loops. The mesangial areas are not expanded and they're not hypercellular. I'm almost having a hard time pointing out where the mesangial areas are because they're not expanded and they're not hypercellular. There's no capillary wall thickening. They're thin and very delicate. And the epithelial cells, the parietal epithelial cells lining Bowman's space, are only one cell layer thick. There's no proliferation of Bowman's capsule epithelial cell lining, which would indicate a crescent if we did see that. So we'll talk more about that later. So this is a normal glomerulus by light microscopy. Normal/baseline immunofluorescence. I don't like saying that immunofluorescence is quote unquote negative because there's always a little bit of baseline staining. So these are the typical stains that we do for immunofluorescence. We have IgG, IgA. We just talked about IgA nephropathy. So you should be thinking about what you might see by immunofluorescence with IgA, IgM, C3, C1q, both of these are complement indicators, kappa and lambda light chain, albumin, and fibrinogen. This is IgG, and usually there's no more than trace to 1+ intensity staining and no granular areas. When we report immunofluorescence, we talk about intensity of staining from 0 to 4+, the location of the staining along the capillary wall in mesangial areas or in the tubules, and the quality of staining. If it's linear or granular or pseudogranular, then we have to talk about 3 different things: location, intensity, and quality. So going back to normal electron microscopy, where we have our mesangial cell, our fenestrated endothelium, our glomerular basement membrane, and our podocytes that are not effaced, our first disease is minimal change disease in the nephrotic side. So with minimal change disease, you will see normal glomeruli by light microscopy, normal staining by immunofluorescence, and diffuse podocyte foot process effacement. That is what we find on minimal change disease. With focal and segmental glomerular sclerosis, the first thing you should know that this is not normal. Both of these diseases present with proteinuria, but only one has normal findings by light microscopy. So as soon as you see abnormalities by light microscopy, minimal change disease is out of your differential diagnosis. Focal and segmental glomerulosclerosis refers to focal versus diffuse, meaning focal less than 50%, diffuse greater than 50% of the total glomeruli in the sample. Segmental versus global refers to less than 50% or greater than 50% of a single glomerulus. So when I say focal and segmental glomerulosclerosis, I'm referring to some of the glomeruli in the sample, less than 50%, and some of those individual glomeruli have a lesion, not the entire glomerulus, so focal and segmental. So you see segmental scarring in some of the glomeruli. Immunofluorescence microscopy is usually normal. There's some allowable staining for IgM and C3, and then you have foot process effacement by electron microscopy. If it's primary FSGS, there's usually global foot process effacement, diffuse, all over the entire glomeruli. If it's secondary FSGS, there's usually segmental foot process effacement, meaning some areas have effacement and some areas are intact, like our normal glomerulus or capillary loop by electron microscopy. Secondary FSGS is usually caused by other renal diseases. So hypertension, diabetic nephropathy, prior glomerulonephritis can cause segmental scarring like this due to injury. Primary FSGS can be idiopathic or can be caused by those types of injury that I mentioned before, since you're going to see global foot process effacement going back to your antibody, your allergic reaction, your familial disease, your cytokines. Those are the things that would cause primary FSGS with global foot process effacement, and it's the exact same picture that you would see in primary FSGS as you would see in minimal change disease, except minimal change disease will have normal light and normal immunofluorescence. I hope this is making sense. Membranous glomerulopathy here, again, light immunofluorescence and electron microscopy. This is not normal. All of these patients have nephrotic syndrome, but this shows significant capillary wall thickening by light microscopy. Remember, the normal glomerulus had very thin and delicate capillary loops, and you could see the light by light microscopy coming through the capillary tuft. You can barely see it. There are some openings, but these are very thickened capillary walls. By immunofluorescence, we have granular capillary wall staining with IgG and C3. That's the finding on membranous glomerulopathy. By electron microscopy, we have our spike and dome pattern. Hopefully people are remembering from med school, you have the spike and dome pattern that's better appreciated on silver stain, but the representation of that on electron microscopy is, here's our lumen, here's our fenestrated endothelial cell border, here's our glomerular basement membrane with these regularly sized and regularly spaced electron-dense immune complex associated deposits that are trying to be walled off by the lighter gray glomerular basement membrane. The glomerular basement membrane doesn't want them there. So it's a reaction to them, and they reach up and cause the spikes, and the dome is the immune complex deposit. On a silver stain, it's the best stain to see or to use to evaluate for membranous. We see the same spike and dome pattern here. So the silver stain marks the glomerular basement membranes and the tubular basement membranes, for that matter, black. And then these little pink nodules along the subepithelial surface of the capillary wall or the glomerular basement membrane are the immune complex deposits on the silver stain. So on an electron microscopy image, they are dark gray and dense. That same representation of them on the silver stain is showing the pink immune complex deposition here. We found out around or about 2009 that membranous glomerulopathy is caused by an antibody. In primary cases of membranous glomerulopathy, there was a big finding that happened around about 2009 that showed that anti-PLA2R was a responsible antibody for most cases of primary membranous glomerulonephritis. Membranous can be primary or secondary. It's usually associated in secondary causes with some sort of neoplasm, usually a hematolymphoid disorder. Other kinds of things can cause secondary membranous too. Histopathologically, they're indistinguishable, and that's why we need the antibody on the tissue or in the serum to determine if anti-PLA2R and now many other antibodies are present to determine if it's primary or secondary. Before 2009, we used the Einrich and Scherg classification to stage membranous. So we have A, B, C, and D here early. Those deposits are subepithelial and they're not bothering the glomerular basement membrane quite yet. They're just sitting on top, and our podocytes still have some degree of effacement or non-effacement. In stage 2 or B, we have more immune complex deposits in red, and now we see the spikes of the glomerular basement membrane trying to wall off these deposits, and now we have some more podocyte foot process effacement. By stage C, the immune complex deposits are becoming more chronic, and on electron microscopy, when deposits are chronic, they become electron lucent, they become lighter. So if you see an electron lucent deposit, you know that it's been there for a while. And then now they're entirely absorbed within the glomerular basement membrane. And this is why we see such prominent capillary wall thickening. In very chronic states, in panel D, we see that the immune complexes are gone. The glomerular basement membrane is still somewhat thickened, and now we have retention of our normal foot processes. So that's membranous. Diabetic nephropathy. Everybody knows about Kimmel-Steele-Wilson nodules. Here we have a PAS stain that shows nodular mesangial matrix expansion in the absence of hypercellularity. We have another disease later that's going to show mesangial expansion with mesangial hypercellularity. So now I want you to appreciate nodular mesangial matrix expansion without hypercellularity. It's just the matrix, not the cells. These are Kimmel-Steele-Wilson nodules. On immunofluorescence microscopy, there's bright linear staining with albumin, and you can see the nodules here as well. And the electron microscopy finding is glomerular basement membrane thickening. You can't tell it here, but there's mesangial expansion of the matrix here without any hypercellularity, and markedly thickened glomerular basement membranes above 600 nanometers is when we start to worry about diabetic nephropathy before we have any clinical information. In renal amyloidosis, we have mesangial expansion that's much more haphazard than those nodules we saw in diabetic nephropathy. It's sort of angulated, can also involve the blood vessels, and we have by immunofluorescence, if it's light chain based amyloid, some sort of predominance of staining for kappa or lambda. As I said, we talk about intensity, location, and quality. So if I see 4+ staining with lambda and 1+ staining with kappa, I know that there is too much lambda, not enough kappa, and there's a discrepancy because kappa and lambda light chains usually stain with the same intensity. And then by electron microscopy, we see our prototypical haphazardly arranged non-branching fibrils that average 7 to 12 nanometers in diameter, around about 10 nanometers each. So that's renal amyloid. The stain that we look to for any type of amyloid is Congo red. So we have Congo red staining in the tubular basement membranes, in the mesangial areas, and along the capillary walls that upon polarization shows that green, apple green birefringence, Congo red birefringence for amyloid. By electron microscopy, we have 3 loops here. Loop number 1, loop number 2, loop number 3. Loop number 1 and 2, loops number 1 and 2 look okay. Here's our glomerular basement membrane, fenestrated endothelial cells and podocytes. Here we have this triangular sort of electron, somewhat loosened deposit that on higher power can show our haphazardly arranged fibrils. This is referred to as spiculated amyloid or eyelash formation on light microscopy. And it's very key for your boards to know that there's non-branching haphazardly arranged fibrils that average about 10 nanometers in diameter for renal amyloidosis. Amyloidosis is key because it can involve other organs like the heart and the GI tract. It's a systemic disease, usually caused by a plasma cell dyscrasia or a lymphoproliferative disorder. It's common in older patients, and they usually have nephrotic range proteinuria. Of all the several thousands of types of amyloid, light chain amyloid is one of the more common ones. So AL stands for light chain amyloid, not lambda, as opposed to AA amyloid, which is serum amyloid A, which is associated with chronic infectious diseases or just chronic diseases. So in 75% of light chain amyloid, the responsible light chain is lambda rather than kappa. It's Congo red positive, it's non-agyrophilic, which means that the mesangial expansion is not silver dense, as opposed to diabetic nephropathy, which does have silver dense nodules, which is another way that you can differentiate these two. As I said, there's mesangial matrix expansion, but only one is Congo red positive and non-agyrophilic, whereas diabetic nephropathy is Congo red negative and has very silver dense mesangial nodules. Moving on to nephritic diseases. So I was in utter confusion in medical school when I was trying to characterize all of these diseases, all of these different appearances on by different types of microscopy. So I came up with my quote unquote nephritic mnemonic, which was APGAR. If you think about what's happening when someone's getting an APGAR score, it's a very tense situation, very acute, there's blood everywhere, they're analyzing the baby, they're trying to figure out what's going on. So I use that to sort of characterize nephritic renal pathology diseases. So we start with the A, IgA nephropathy, which really isn't a nephritic disease, but I'll explain more about that later. P, post-infectious GN. The G is Goodpasture syndrome or anti-GBM, which are basically the same thing. Anti-GBM refers to when it's renal limited. Goodpasture syndrome refers to when there's pulmonary involvement as well. Alport syndrome, not necessarily nephritic, but patients have hematuria. And then RPGN, which is, when I was in medical school, this old-fashioned term that was a catch-all for all acute presentations, usually with crescents, and it was rapidly progressive glomerulonephritis. So that's where we get APGAR. Not all of these diseases have an acute presentation. However, if you're taking the boards or some kind of test and they're telling you about proteinuria, nephrotic range proteinuria, 10 grams of proteinuria, none of these diseases should be in the differential. So some of them are nephritic, and then some of them are just not nephrotic, if that makes sense. IgA nephropathy, we talked about Berger's disease. Here's our disease where we see mesangial hypercellularity. Diabetes, we saw nodular mesangial matrix expansion, and now we see mesangial hypercellularity. We also see a tubule nearby with a red blood cell cast. There's the hematuria in IgA nephropathy. By immunofluorescence, we see granular mesangial IgA staining, that's staining brighter in intensity than any other reactant, hence IgA nephropathy. And by electron microscopy, we see electron densities in the mesangial areas that are representing the immune complex deposition that we see by immunofluorescence. A little bit of a complicated slide here, but I'll walk you through it. Here we have an IgA antibody. The teal are the heavy chains. The white boxes are the light chains. The blue circles are the hinge region of an antibody. Within the hinge region, there's a 17 amino acid strip here that has these red indicated with the arrows galactosylation sites. In IgA nephropathy, their hypothesis is that the antibody has poorly galactosylated IgA glycoforms. We want the isoforms to look like this with galactose present. In IgA nephropathy, there's an antibody that looks too much like these, not enough galactose. So we have these poorly galactosylated IgA isoforms. And we think about the two hit theory when it comes to IgA. Hit number one, high serum levels of these poorly galactosylated IgA glycoforms. Hit number two, development of hinge region reactive IgG and IgA antibodies that cause our IgA immune complex formation. So what happens is, and I'll walk you through this as well, we have our poorly galactosylated IgA isoform with the red star. We have our naturally occurring IgA and IgG antibodies that detect this abnormality and attach to it, causing an immune complex to form. The immune complex formation causes other serum reactants to come in and address the issue, fibronectin, CD89, and other soluble factors. This immune complex circulates and gets caught up and trapped up in the mesangial areas of the glomerulus. And then you get monocyte and macrophage infiltration, kidney injury, hematuria, and proteinuria. The pathogenesis of IgA nephropathy. If you think about it, it's kind of sad because your body's trying to help you out. It's recruiting its own naturally occurring antibodies to detect of what appears to be a foreign object and dispose of it, but it gets trapped up in the mesangial areas and actually causes injury to your own kidney. So that's sort of the story with IgA nephropathy. We have post-infectious glomerulonephritis. Here, we don't have wide open capillary loops. Every single capillary loop is filled with neutrophils, polymorphonuclear neutrophils, and it causes an exudative appearance to the glomerulus. By immunofluorescence, we have this garland-type subepithelial staining with IgG and C3. And then by electron microscopy, we have our PMN happily sitting here in the capillary loop. And then we have subepithelial hump-like dense deposits. Hopefully you can see those hump-like dense deposits. If not, I'll add some arrows. Here they are. I'll take them away, put them there again. Hump-like deposit. So that's very different from membranous. Number one, membranous is a nephrotic disease. And number two, the subepithelial deposits in membranous are diffusely located along the glomerular basement membrane, whereas these hump-like deposits are just rare and infrequent. Let's talk a little bit about crescents. So here we have our mesangial area, our glomerular basement membrane with a big hole in it, and we have our fenestrated endothelial cell surface and endothelial cells. Rupture or breakage of the GBM allows fibrin and fibrinogen to escape into the urinary space. That fibrin and fibrinogen irritates those teal blue that I showed you before, and now they're more of a navy blue parietal epithelial cells and causes them to proliferate. So the fibrin are the things here that look like bacon strips. That's what causes a crescent. Generally speaking, crescents are nonspecific, but there are 3 diseases where if I see them, I hope that the clinical team has ordered an anti-GBM antibody, ANCA serologies, and lupus serologies, because those diseases, ANCA, anti-GBM, and lupus, are the 3 key diseases where we typically see crescents. So that's where we have our clinical serologic studies that we need to help us come up with a diagnosis. And here they are by light microscopy. So you can imagine why there's oliguria in nephritic disease, especially those with crescents. The capillary tuft is being pressed. So how is the afferent arteriole going to come in and filter the blood and come out as the efferent arteriole with this much compression on the glomerular tuft? In addition, there's nowhere for the urine to go. The Bowman's space is being encompassed by this cellular proliferation of Bowman's capsule. So that I can't even imagine how there's functioning. The kidney has millions of nephrons. For adequacy on a kidney biopsy, all we need is 10. So if we're represented by diffuse crescent formation, it should make sense why there's poor functioning and poor urine output in kidney diseases that have this finding. With anti-GBM/Goodpasture syndrome, the G of our APGAR, here we see a beautifully illustrated crescent pressing the glomerular tuft here. We have, hopefully you can see the crescent in the background counter stain, a compressed tuft with bright linear staining along the capillary wall with IgG. Again, we look for quality, location, and intensity. And we see bright linear staining with IgG and anti-GBM. And then we see, not all the time, sometimes breaks in the capillary walls here, or ruptures in the GBM. I use GBM and capillary wall interchangeably. On the silver stain, there is no reason in normal glomeruli on silver to see this pink fibrin material within the capillary loops, and then we see breakage of the glomerular basement membranes here. This must have connected up to this, maybe this connected up to this, but they're broken. Fibrin is coming out. And again, in a normal glomerulus on the silver stain, none of this pink material should be here, and all of the capillary wall should be intact. Here's a higher power image of the same thing, where now we're seeing the fibrin leak out, irritating the podocytes and causing proliferation, and that is the basis of a crescent. Here we have a mixed presentation. Membranoproliferative glomerulonephritis or glomerulopathy can present with either nephrotic or nephritic syndrome, depending on the timing of the disease. By light microscopy, we have a mesangiocapillary pattern where we have mesangial proliferation and capillary wall thickening with intervening cells in between both layers of the capillary wall. Immunofluorescence staining is very positive, predominantly positive for C3. And then here by electron microscopy, we can see splitting of that glomerular basement membrane with immune complex densities and cellular fragments from what we saw over here. So that's just the electron microscopy representation of what we're seeing by light microscopy. This used to be called MPGN, and it still is because it represents the pattern that we see by light microscopy. However, MPGN used to have 3 subtypes, type 1, type 2, and 3. Fast forward to now, we've realized that all 3 of those subtypes had very predominant staining with C3. So the quick answer is that the name of this disease is usually referred to as C3 glomerulopathy because there's predominant staining for C3 in disease and disorders of the alternate pathway of complement. Most of these patients are hypocomplementemic. Lupus nephritis. There's variable findings. Lupus nephritis has 5 to 6 different classifications, depending on at what time you read the classification system, what year. And it can have a variety of different findings by light microscopy. However, by immunofluorescence, one thing that is key is full house staining, meaning staining with IgG, IgA, IgM, C3, C1q, kappa, lambda. And so that's what we refer to as a full house. All 3 of the heavy chains, both of the light chains, and some complement. That immune complex deposition is in mesangial areas, in subendothelial areas between the endothelial cell fenestrations and the glomerular basement membrane, and some subepithelial deposits too, depending on which classification. Class 5 lupus nephritis looks histologically indistinguishable from membranous. A lot of times we call it membranous lupus. So here's a little graphic of all the different classes of lupus nephritis. Here's class 5 looking like membranous with our diffuse subepithelial immune complex deposits. Class 3 and class 4 have a lot of immune complex deposition and crescents. Class 1 and class 2 represent milder disease. So I know that was a lot. We'll end here with a case presentation that I'll go through pretty quickly because I want to have time for questions. So we have a 57-year-old woman with a past medical history of hypercholesterolemia who was admitted for fatigue, acute kidney injury, and acute anemia. She was doing very well and she had until she had a COVID infection, and then she developed fatigue, decreased tolerance of daily activities, and a lot of other symptoms. Lots of laboratory data here. I'll walk you through it. Hemoglobin was very low, but what we're looking at is that her last known serum creatinine was 0.8. And look at it now, 6.28. Normal range is here. She's got markedly elevated free kappa light chains compared to lambda. Her free kappa to lambda light chain ratio is 3,034.88. Here's a normal range here. She has a spot UPCR and 24-hour protein of 11 to 12 grams. So that's way more than 3.5 grams per day. Negative ANA, that's her lupus serology's ANCA. So they started working her up because a creatinine of 6.28, we need to start looking at our quote unquote RPGN. Negative hepatitis serologies, her immunofluorescence interpretation of her SPEP showed a monoclonal free kappa light chain. So we have a lot of information. Hospital course, he did urgent plasmapheresis, gave her steroids, gave her chemotherapy because they probably knew they were dealing with a myeloma. Skeletal survey showed findings consistent with diffuse myelomatous involvement of the osseous structures without pathologic fracture. A bone marrow biopsy performed 5 days after the kidney biopsy, which I'm about to show you in a second, showed lots of heme path stuff here. but basically a hypercellular bone marrow with increased monotypic plasma cells. And the comment will skip down. The overall findings are consistent with the plasma cell neoplasm. Okay, so looking at the kidney biopsy, we have the glomerulus by H&E. Light microscopy looks okay. A little bit of mild mesangial expansion, but certainly no nodules and certainly nothing that looks like amyloid. That is confirmed by the PAS. Still looks pretty good. A little bit of capillary wall thickening. Silver stain looks okay in the glomeruli. Again, a little bit of mesangial matrix expansion, but certainly no hypercellularity. The trichrome stain showed a lot of fibrosis. That's a lot of blue on this kidney. So we use that just like in liver biopsies to determine how much fibrosis is there. And it was pretty chronic. It's a 57-year-old woman. She's got a lot of fibrosis. When I started looking carefully at the tubules, I kept seeing atypical casts. So that's one. Here we see one here with what looks like a fracture. Here we see the cast should not take forms and shapes. They shouldn't be altering the structure of the tubule. So we have casts here that are atypical and surrounded by cells. So there's a cellular reaction to these focally fractured casts. Here we even have histiocytic multinucleated cells that are within the tubules. And here's one that's actually trying to eat one of those casts. Here on the trichrome stain, I had a mentor that told me to look for the psychedelic color. So the cast can sometimes be kind of pale pink and then red, but they both have a cellular reaction on this trichrome stain. This one's sort of shaped like a golf club. We see that it's distorting the tubule and abnormally shaped here. And then fractures on PAS, fractures on the silver. When I looked at my immunofluorescence, there was much brighter staining for kappa than there was for lambda, as we might expect with those numbers. And while there was a little bit more linear staining for kappa than lambda in the glomerulus, trust me, this is the same field, we can see the increased staining for the cast by kappa here as well. I always follow up with a immunohistochemical stain for kappa and lambda. And unfortunately, in this case, not only did we see increased staining in the casts for kappa, but we saw increased staining in the plasma cells of the inflammatory infiltrate in the interstitium with kappa relative to lambda, as you can see here. So basically what ended up happening is she had a myeloma, light chain cast nephropathy, and involvement of her kidney by her myeloma with a plasma cell neoplasm. So I was very glad that I added on the immunohistochemical stain for kappa and lambda, because if I hadn't, which a lot of people don't do, I wouldn't have been able to see the differential in the plasma cell staining between kappa and lambda, because that doesn't really show up, as you saw, on immunofluorescence. So I saw this and I literally ran to HemePath, because remember the kidney biopsy, the bone marrow biopsy was done after the kidney biopsy. So I took it down to HemePath. They worked it up. By that time, they had the bone marrow biopsy and the kidney biopsy to review, and they seconded the diagnosis of the plasma cell neoplasm involving the kidney and in her bone marrow. So to summarize, I know that was a lot of information. Renal pathology is very complex. The key to most board questions is in the clinical presentation, with the exception of that last case I showed, right? Because she had 6 grams of proteinuria, but she ended up having plasma cell neoplasm. And also knowing each morphologic presentation for each disease. That's what's going to really help you to arrive at the diagnosis. And I have 10 minutes for questions, and thank you so much for your attention and time.
Thank you so much, Dr. Ellis. That was amazing. You covered so much in such a short frame of time. And like you said, you left plenty of time for questions. My question is, can I get a printout of that, a print of that trichrome to hang on my wall? That was an amazing image.
Wasn't that amazing?
I loved it. As you can maybe see behind me, I do like bright colors
Yes.
every now and then.
I can see that. Thank you.
To everyone who is here, if you have any questions for Dr. Ellis, please put them in the Q&A or the chat. I haven't seen any yet, but we do have until 8 minutes until the top of the hour. So,
okay. Well, did you have any, Raul?
well, you know that I shouldn't be trusted with a medical kidney biopsy. So,
oh, you'd be great.
if you say so.
it's it's like I said, with the app, it was just, it's a lot coming at you, especially as a medical student. And that's why I sit before you now as a renal pathologist. I was so frustrated in medical school that I literally had to just stop and teach it to myself. And in the process of teaching renal pathology to myself, I started to love it. I started to be so enamored by the things that our bodies do, like those, multinucleated cells trying to eat the cast, and those casts are going nowhere. They're not, the treatment for myeloma light chain cast nephropathy is basically transplant, renal replacement therapy, because those casts don't go away. And so, and just like with the IgA and the autoimmune disease, it just really emphasized how amazing the body is and just how amazing the kidney is as well. So I went from like hating renal pathology to here I am a renal pathologist. So I think it's just a very interesting subspecialty.
I love it. And briefly, I'll just say, I think having a framework is so nice, because once you have a framework, then any piece of information you obtain, because we obtain this information in a scattershot fashion, you have a place to put it rather than it just sort of hanging loose in some rogue neurons that may or may not ever connect to anything else.
Yeah, the framework is start with it, especially for board questions, because how are you going to try to lasso all that information, when you have, so much more to learn, just thinking about, is it nephrotic or nephritic, and if it's nephritic, think about your APGAR, and then use the pictures and the other information they provide in the question to differentiate which one of those diseases it might be. On questions like on board questions, the answer is staring you in the face. You just have to know how to get to it and know what to eliminate as the wrong answer. And so if you have a framework of how to approach those questions, that's what will help you. You're keeping in mind that there's not a lot of renal pathology on the pathology board. So, but if you get 2 or 3 questions, at least you'll know what kind of framework to approach them with.
Absolutely. The questions are starting to come in. I'm going to toss them at you in the order I've seen them.
Okay.
Dr. Ratnatunga asks, do you do EM on all biopsies?
That is a wonderful question. So how I do it, which may vary at your institution, is that I do EM on all native kidney biopsies. I do not prioritize EM on them. They all get EM. I have a system in place for how I determine if I want to do EM on transplant biopsies, which we didn't get to. I didn't talk about any transplant pathology. So if the biopsy is new, if it's a protocol biopsy, if the transplant biopsy is new, if the patient has no proteinuria, if they have a cause of end-stage renal disease that wasn't glomerulonephritis, if they've had EM within the past 6 months, I have like a little checklist that I do, and I can say, I don't need to do EM on this biopsy to help with my turnaround time. However, we always reserve the tissue and glutaraldehyde so that if we do need to go back historically, we can do that. So we always process for EM, but we don't always scope the images, if that makes sense.
Gotcha. That makes sense. Thank you.
Yeah.
Next question, Dr. Pramantaleke, apologies if I don't pronounce any names properly. Can you sometimes see mild increase in mesangial cells in minimal change disease?
That is also another good question too. So, the key finding in minimal change disease is what they beat into your brain is normal light microscopy, normal immunofluorescence, and then diffuse foot process effacement by electron microscopy. Within the spectrum of normal, you can have a little bit of wiggle room, because that patient, it's not always a kid. You can have minimal change disease in adults. May have a little bit of some kind of other disease. Adults have hypertension, so you can see little subtle changes like that. But for the large part, normal in terms of no crescents, no mesangial proliferation, no active acute proliferative features when I say normal. And usually in kids, they don't have that anyway, because they don't have high blood pressure and diabetes and other diseases. So yeah, I would say, mesangial hypercellularity for me is more than about 4 mesangial cells. So if you occasionally have 5 or 6, am I going to say this isn't minimal change disease? Absolutely not. Especially if my immunofluorescence is normal and my electron microscopy shows what it's supposed to show, then that's still compatible with minimal change disease.
Perfect. Thank you. Not a question for Dr. Ellis, but someone asked if the lecture will be recorded and made available. And I just want to make sure everyone saw that this lecture, yes, is recorded and will be on the ASCP Virtual Pathology Grand Rounds webpage.
Wonderful.
Okay, and back to questions. Dr. Lehman asks, how often do you see IgG4 associated damage in the kidney?
That is rare, but it is a thing. I have had cases of that. It's not common at all. IgG4 disease can obviously affect the kidney. It's usually that as you would know, Raul, that retroperitoneal fibrosis, and you have IgG4 positive cells that have a certain ratio of positivity compared to normal IgG.
Right.
I, interestingly enough, had a partial nephrectomy for papillary renal cell carcinoma. It might have been someone else's case, and they came and said, the background kidney has a lot of inflammation. I'm not sure what's going on. Can you look at it? And it had all of these plasma cells. And so we did the staining, worked it up, and it actually had a really high proportion of IgG4 compared to regular IgG plasma cells. And we made a diagnosis of possible IgG4 disease in the background kidney of a papillary renal cell carcinoma, partial nephrectomy removed for the tumor. So of the two cases that I've had, 50% have been in oncologic, for GU related kidney rather than an actual kidney biopsy. So it's not common, to answer your question. This topic and this question emphasizes the importance of, on nephrectomies for tumor, making sure you take a look at the background kidney, just like Raul in the liver. When you have a liver tumor, you have to check that background liver parenchyma for any abnormalities. So
that's amazing. Those cases, in addition to the high proportion of IgG4 positive plasma cells, do they also have the storiform fibrosis and obliterative phlebitis, or?
Because I had so much kidney in the partial nephrectomy compared to my 8-gauge needle biopsy for kidney biopsies, it did have the storiform fibrosis, but that is hard to see on a biopsy. And so on the one that I had on a kidney biopsy, it wasn't as obvious, but I've seen kidney biopsies, not my cases, where it is a little bit better to appreciate. Yeah.
That is amazing. One more at the moment. An anonymous attendee asked, how do you assess for adequacy and divide up tissue for different studies?
Oh, that's a great question. I wish I have a slide about that, but I in the interest of time, I left it out. So, yeah, so we have our technician that attends all harvests of kidney biopsies. They go down there with a cart, with a dissecting microscope, and evaluates the tissue core for glomeruli in the cortex and then medullary tissue. Usually there's about 2 or 3 cores. We take a small portion for immunofluorescence that has cortex. We have to have glomeruli for immunofluorescence. We have to have glomeruli for electron microscopy. So we usually select the cortical ends of 1 or 2 cores for those studies, and then just submit the whole rest of it for light microscopy. And for adequacy, I like to see at least, as I said before, 10 glomeruli for the entire study. So that includes light immunofluorescence and electron microscopy, sharing 10 glomeruli when there are millions of nephrons in the kidney. So I'm actually amazed that we are able to make a diagnosis as often as we are with, a minimum of 10 glomeruli in the entire kidney. And it's, that's because, as you would know with liver, medical disease is more diffuse than localized tumors. So that's also what makes it a little bit more difficult.
Perfect. All right, that's all the questions I've seen in the Q&A and the chat. I'll give it another couple seconds if anyone wants to slip one in under the wire.
Are they able to unmute? I don't know
that they can in the presenter version of this.
Gotcha. Yeah. I'd be happy to answer any more. Looks like we're ending right about on time. That was wonderful. Thank you.
That was fantastic. Thank you so much, Dr. Ellis. This was really great. We really loved having you, and I hope you enjoyed being here.
I did, very much so. Thank you for the invitation, and thank you everyone for listening.
Yes. All right. Have a good afternoon or evening or possibly morning, everyone.
All right. Take care.
Thank you, everyone.
Thank you.